Thank you, Abhirami. Come, Ranjit, please come. We have very, already we are running more than 1 hour late, the program. So probably we won't take up any questions. Probably we can meet them there in the lunch area after this. So let us start, Ranjit.
Yeah, at the outset, let me thank Dr. Raju and the Surgeon Chapter for giving me the opportunity to participate in this debate. When I heard it was Abhirami, I had some trepidation. But then when I saw the topic, I thought that, maybe I stand a chance in front of her. So this is, can I have the slides? So Abhirami has actually skirted around the issue very expertly, but I am going to come directly to the point with evidence. She doesn't have any evidence in her hands. So my argument is, of course, we don't need to use coronary angiogram fraud. So why are we talking about this? We know that transplantation provides a clear survival benefit and on the long term, but it is offset by the increased perioperative risk which is there for the first 100 days. And most of this is driven by cardiovascular factors. And the controversy which is there is not whether you need to subject high-risk patients to coronary angiogram. Here the controversy is actually on the asymptomatic coronary artery disease patients, whether we need to do anything about it if they do not have any symptoms. If so, how does aggressively looking for it help? And if we find something, does intervention actually make any difference to the outcomes? This particular thing was studied in the general population. So in the general population, you have the CARP trial which came out 20 years back, followed by another Dutch study few years later, which looked at the high-risk coronary artery disease patients and whether intervening in these patients before a major elective vascular surgery, which is what a renal transplant would fall under. So in this general population, they have clearly found that there is no use doing a renal revascularization. It doesn't change anything as far as their long-term outcome is concerned. So in the general population, all you do is the patient doesn't have symptoms, their ECG is normal, their echo is normal, the TMT is normal, you just go ahead with the surgery. However, we know that our patients are at high cardiovascular risk. Our dialysis patients especially at a high cardiovascular risk, but all of this need not be because of atherosclerotic cardiovascular disease. So there's a lot of non-atherosclerotic factors which play, including LVH, arrhythmia, sudden cardiac death, arterial calcification, etc., which may play a greater role and may not be corrected by just doing an angiogram. Now, as Abhirami said, the international guidelines are all over the place. You have most of the societies coming up with their own guidelines on how to screen cardiac patients. And it's only one of the guidelines, like the Renal Association, which actually leaves it to the physician whether they want to do any screening at all for the asymptomatic patients. And actually they leave it, they find it okay to go ahead and transplant these patients without any further screening. Now, who are these high-risk asymptomatic candidates? The KDIGO and the AHA have put down criteria as who they think it is, the diabetics and the patients with known cardiovascular disease, and also several other factors including dialysis vintages down there. Now, the AHA update which came up in 2021, which Abhirami has already shown, there is no controversy when it comes to the high-risk patients. We have to refer to the cardiologist, and I agree with her. I mean, if you're not sure about this thing, you go directly to an angiogram in these patients. The guidelines mention that in the patients who are high risk, you have to undergo a functional assessment for further stratification and only then go for a coronary angiogram. This is what they say. Now, coming to the so-called evidence which is being presented for coronary interventions. Now, this Manscale trial in 1992 had 13 patients each in each arm. The 26 patients, 13 patients were revascularized, 13 patients were medically treated, and at the end of 8 months, they found that 10 out of the 13 patients had coronary events. So, however, if you look at it, only 20% of all the patients who underwent a coronary vascularization had significant disease, which was amenable to intervention. And the medical therapy was woefully suboptimal. They received just aspirin and short-acting nifedipine alone. There was no ARB, no beta blocker, no statins. So the direct-to-cath approach, which some misguided people still follow, where they have different centers follow different things, but some go directly to cath, some follow some risk stratification mechanisms. But most of these studies are single-center observational studies. The only RCT was that pathetic Manscale study which was there. They all claimed that they found a high incidence of coronary artery disease, significant coronary artery disease burden, and that revascularization had good results. But then there was no comparative medical therapy arm in any of these. So unless you have that, their claims of their revascularization being helpful does not hold good. So that's the reason why you do not recommend doing an angiogram unless you feel that revascularization actually is going to benefit the patient in any particular manner. Coming to the landmark ischemia CKD trial. So this basically studied a multinational randomized controlled trial with 777 patients. They looked at stable coronary artery disease patients. Some of them had chronic stable angina. Majority of them actually, less than 50% of them actually had angina in this particular thing. They looked at CKD 4 and lower. 50% of the patients were on dialysis. And as a screening test, they used moderate to severe ischemia on a stress test. And those who they deemed to be at high risk, they either randomized to a medical therapy or they went directly to an angiogram coupled with the medical therapy. Followed them for 3 years, and they found that the primary outcome of death and acute MI was the same, secondary outcome was same, net benefit outcome was same, no clear benefit by doing an invasive strategy. But look at this, the harm. There was a 4-fold increase risk of stroke, 48% increase in the risk of death or MI after, death or going on dialysis for the patients who were pre-dialysis in this group. Now, to the study which is relevant to this, they did a subgroup analysis, even though it was only post-hoc. 194 patients of these were randomized, at randomization were on the wait list for kidney transplant. So they did it in 94 patients that underwent invasive therapy, 100 patients medical therapy, absolutely no difference even in these patients. So you have evidence right there saying that invasive therapy, invasive strategy is not of any use in screening these patients. However, there is some critique regarding how only 50% did not go revascularization. Of course, that had to do with the screening test that was used. 20% of the listed the conservative patients actually underwent revascularization over 3 years. But the problem is that out of these, more than 50% was for non-protocol reasons. And basically it's ingrained into the physicians that these people are at high risk. So while on the waiting list, even though the medical therapy had not actually failed, the treating physicians became nervous and they ordered a coronary angiogram. So that is something that needs to change. There is absolutely no evidence actually that revascularization or subjecting them to an invasive strategy actually does any difference on a long term. These are 2 other studies which looked at this thing. It's the Herzog et al. Was a post-hoc study. You have a registry data from Brazil where they looked at revascularization and long-term mortality post-transplant. And you had a large USRDS data which actually looked at any screening, stress testing within 18 months before transplant, and looked at short-term mortality, 30 days post-transplant, MI and death. And they both found that there was absolutely no difference whether you screen these patients at all or not. This is in the asymptomatic coronary artery disease group. You have this meta-analysis which came out, which included ischemia CKD trial and 8 other trials. And that also showed that all-cause mortality, cardiovascular mortality, major adverse cardiac events, absolutely no difference. Regarding the asymptomatic coronary artery disease patients, you had two large retrospective studies, one from the UK, which actually looked at 2,500 patients. They did the propensity score, and they selected out 880 patients who underwent coronary artery disease, and matched them with propensity scores with those who did not undergo, and they found that at 90 days, 1 year, or 5 years, there was absolutely no difference in the cardiovascular outcomes. Similarly, there was this large 80,000 USRDS data that they looked at over 15 years. We're looking at whether they were screened for coronary artery disease in the previous 12 months before transplant or not. Of course, there was a lot of practice variation between the programs, and they used something called an instrumental variable analysis, fancy statistical method to overcome this. But regardless of what they did, there was absolutely no change between the two groups. Whether you tested these patients for coronary artery disease or did not test them for coronary artery disease, there was no change in the primary outcome. Why is it not working? Probably because perioperative MIs are not because of coronary obstructive disease. Mainly unstable plaques are there, and these unstable plaques will not be picked up by your stress testing or maybe ignored by your coronary angiogram. And of course, the decreased coronary reserve flow and the impaired microvascular circulation. And also, not everything is atherosclerotic in this thing. A lot of it could be driven by myocardial fibrosis, arrhythmia, sudden cardiac death, and arterial calcification, where your coronary angiogram is not going to help at all. So, Abhirami was saying that there's no harm, but look at what the evidence shows. It's downright harmful. 4-fold higher risk of stroke in these patients. Exposure to peri-procedural complications. The ischemia CKD trial said that the peri-procedural MI was greater in those who had the invasive strategy. You can have other embolism. Contrast-induced AKI if you're using it in a pre-dialysis population. Radiation exposure, whether you're doing a stress test or you're doing an angiogram, is significantly high. The intervention would delay transplant. Now, the intervention delaying transplant, if you're putting a drug-eluting stent, 3 to 6 months you go. You wait, whether it's a live donor transplant or a waitlisted patient. And in the waitlisted patient, if suppose you're talking about a high immunological risk patient, in the meantime, they might miss out on having a really mashed kidney. You're exposing them to staying on the wait list or staying away from transplant for more period, exposing them to higher mortality. We all know that waitlisted patients have higher mortality. And not to mention the costs which are involved in these tests, the resources which are there, the travel multiple times that they have to come back and forth, the time that they have to spend, and the untoward anxiety that these patients, especially the live donor transplant candidates, have to undergo before they are unsure whether they will be cleared for transplant or not. So, as of now, there is nothing to suggest that any invasive strategy is superior to optimal medical therapy. So, optimal medical therapy is the bulwark of what we do. So, the antiplatelets and statins in all high-risk patients, RAS blockade, the STOP-ACE trial has shown that you should not withdraw RAS blockade in even when your GFR is going down. The patients with previous MI have to be on beta blockers, SGLT2 inhibitors, lifestyle modification for all, diet, exercise, control your blood sugar, control your blood pressures. Make sure that your dialysis is optimized, make sure that your ultrafiltration is placed, anemia is controlled, metabolic bone disease parameters are under control. Then you have this trial, which is the results of which are awaited. These patients are those who are on the cardiac screening test. Whether or not, once you're waitlisted, whether you need to screen them annually or biannually. And hopefully, but the problem is that in order to get onto that test, you have to be screened first. And my argument is you don't need to do that screening in an asymptomatic patient to get onto the list at all. These are two editorials came 10 years apart, to cath or not to cath, and the evidence has not really changed much. Here also, it says that basically it's the intentions, or rather the so-called good intentions of the treating physicians, rather than evidence which is dictating practice by subjecting them to more invasive strategies. So my take-home message is, coronary revascularization is not recommended in stable CAD patients. I want Abhirami to ponder about this. Are you on the dialysis patient side? We know that regardless of their risk, the dialysis patient will be benefited on a long-term basis by doing a renal transplant, or are you on the transplant program side? That is, if you don't transplant these high-risk patients, your transplant program's outcomes are going to look better. So which side are you on? Evidence shows that looking for occult CAD and trying to correct it does not make people feel better or live longer. The focus has to be to compliance of optimal medical therapy and to ensure adequate dialysis metrics. Blindly screening all transplant patients with the coronary angiogram is definitely not the answer. Transplantation is the best treatment for most kidney failure patients with asymptomatic CAD, and we should abolish all obstacles, including screening tests, which are based on dogma rather than evidence. And finally, I leave this for Abhinami particularly to ponder upon, and for the audience as well, where if a patient dies during or after transplant, we feel that it's our responsibility and we feel bad about it. But what about if the patient dies while on the waiting list undergoing workup, and you're delaying the workup because of your screening test, and the patient dies? Acts of omission are not taken upon our conscience. Thank you very much.
Okay. Thank you.